Bismillah ar-Rahman ar-Rahim. I am Dr. Mohibullah Wazir. I give a very brief and clear concept about the diagnosis of typhoid fever. Due to inaccurate diagnosis of typhoid fever and giving recurrent medicine and improper treatment, a lot of cases of MDR and XDR typhoid have been occurred. In United States in 2020, 99% of the patients, the Salmonella isolate was resistant to fluoroquinolone. In Pakistan in 2020, 70% of the patients, they were all the XDR typhoid, in extensive drug resistant typhoid. In 2019, somewhere 16 countries have found the XDR typhoid, although there was no history of these patients to travel to Pakistan. It means that worldwide XDR typhoid fever is being increasing. And the typhoid is found mostly in Pakistan, Bangladesh, India, while the highest number of patients of typhoid in the last year, it was in Afghanistan. Now, how to diagnose typhoid? I make it simple and clear. Number one, history, and number two, examination, and three, then the laboratory investigation. First, history very carefully. In prodromal stage or in stage 1, there will be body aches, pains, headache, severe muscular pain, abdominal cramps, abdominal distension, but the temperature will be low and it will be slowly increasing today, tomorrow, and then the next day in a step ladder fashion. That is, it will be daily increasing from one day to another. Secondly, in the next stages of stage 2, stage 3 and stage 4, when the bacteria multiply in pair species of the intestine, then there will be more abdominal cramps and constipation and diarrhea, distended abdomen and tenderness all over the abdomen. And also there will be sore throat like symptoms to the patient and even maybe cough. The temperature will be slowly increasing and ultimately up to 7 days, then it will be the highest temperature and then it will now plateau, and now treated it will again decrease in a ladder step ladder pattern, that is slowly decreasing from 7 to 8 if treated properly. Then because of then on examination, then you examine the patient, and what you do, look the point. First you make negative all the other diseases by examining responsible for the fever. For example, you make negative, is it throat or chest infection, is it urine infection, is there any sign of malaria, is there any sign of other meningitis or any other disease. By examination, throat, chest, abdomen, and examine all over the body, first to make it negative all the diseases. Then in typhoid, then you suspect it for typhoid. In typhoid you will find number one, temperature with relative bradycardia, that is the pulse will not increase according to the rise in temperature. For example, we say 1 degree rise in temperature, 10 degree pulse will increase, but in typhoid it will be not like that. And then there will be red rose spots also in the chest, in the upper abdominal region. And liver and spleen, hepatosplenomegaly, will also be present in somewhat 50 to 60% of patients. You will feel this hepato and splenomegaly very clearly, and toxic look and continuous temperature not touching the baseline, and the pulse will be relative bradycardia. This will be an examination that you make negative the disease and make these positive findings. Then you suspect the typhoid and then try to investigate it. So, in this way, rolling out all the other causal organism, number one, and then finding this positive, this will be the suspect for typhoid. Secondly, it is said that fever for 3 to 7 days without obvious any other cause, for example, chest, throat infection or urine infection, then enteric should be suspected. Or if you say that if the individual is living in endemic area or have traveled in endemic area some 28 days back, then if the doctor is practicing in the resources constrained setting in that area, which the resources for investigation are not much available, then the WHO has made a program that is AWARE, AWARE, that is access, watch and reserve, and keeping in view all these findings by making negative other diseases and positive some finding for typhoid fever. Then if there is resource problem constrained area, then you can start for typhoid fever the treatment. And then now what are the investigations that you will do to make it clear or confirm? Now please make it clear. First of all, the mainstay, the 100% specific and sensitive is the blood culture, which is very sensitive and at the same time not only specific, but at the same time it will give you the sensitivity about the antimicrobial agent as well. That is why it is the main diagnostic test. But cost and limited, you know, the facilities for culture are not present everywhere and the long time also being taken by it. These are the limitations that give you limit that the culture test cannot be done everywhere. Then more specific than the blood culture is the bone marrow culture, but it is again the costly and then painful and more invasive. And then also the urine and stool culture can also be done, which is also the sensitive test. But because of the limited availability and because of the cost and availability of the facilities, then you can take help of the other investigations, but which are not very specific, but then you will have to think yourself many times to make it clear that it is typhoid. Don't give the treatment with very mild, suspect, because this mild suspect and the improper treatment give rise to MDR and HDR typhoid fever. Now the next test is the Vidal test, and the Vidal test should not be used for diagnosis alone because it is non-specific, it is less sensitive, and also giving the inaccurate result due to cross reactivity with other bacteria. In Pakistan by NIH it is already banned. And then the rising titer of the Vidal is important, that for example today you do it is 1 by 180, it is 1 by 80, tomorrow it should be by 1 by 160, and the next day it should be by 1 by 130, 320, then it is a failure, otherwise if not, of course. And it also comes positive because of the previous infection or vaccinated area. Okay, that's why the Vidal is not the diagnostic, and it is banned in Pakistan, it should not be done. And then is the Typhoid test. Typhoid test is again also, it was claimed that it is 95-97% specific and sensitive, but now it is proved that it is not 95% sensitive and specific. And study in Karachi in several hospitals Karachi, and it was done, and it was found that sensitivity is 26.7 and specificity is 61.5. That's why the Vidal test also the typhoid test should also be not 100% trusted upon, because the specificity and the sensitivity is not that as it was being claimed in earlier days. Now, what to do? I give brief. Number one, make negative all the others by examination, by history examination, and number two, find the positive finding for typhoid by examination, the abdomen, the chest, the thorax, and the pulse, and then the CBC. Again, don't forget the complete blood picture. It will give you, number one, the relative leukopenia. That is again one important test. In very few percentage there will be leukocytosis as well. It might make confuse, but in most of the cases it will be relative leukopenia. Platelets will be normal. Okay, and then make it combined with the other easily available and the less cost test, for example, the typhoid, and you can, when the CBC combined and the clinical examination, if the culture is reasonable, then you decide it very easily and then very correctly with full confidence. Then your patient, inshallah, you will not misdiagnose the case and it will not lead, and the patient will be treated. Then give the treatment properly for the proper days and the proper dose and proper treatment. And because this is the typhoid is more common in children as well, that's why the dose in children should also be properly calculated, and you should know the dose per the dose per kg body weight or any proper dose for the children as well. Thank you very much.